Yeah. First of all, good morning everyone. Welcome you all. So, our case is a 36-year-old gentleman who is smoker with strong family history of coronary artery disease with past history of PTCA to mid RCA for NSTEMI for 1 back. Uh, he has the negative TMT at 9 months at 4-month follow-up and during TMT, the TMT was stopped due to during claudication. His LDL is 65 per 77, blood pressure 120 by 70. He is scheduled for some dental procedure at 4 months for PTCA and advised to reduce or stop his blood thinners. He is currently taking Telmisartan combination plus aspirin 75 plus Ticagrelor 90 mg and Rosuvastatin 20 milligram each. His recent echo shows LVEF 50% with mild inferior hypokinesia with grade 2 diastolic dysfunction. So this is our case. Patient is already taking DAPT with aspirin or any other P divider. So, what is the question for our discussion? Can we switch to clopidogrel and stop aspirin beyond 3 months? And the second question is, what is the role of clopidogrel beyond learning as a single antibiotic therapy instead of aspirin? So, as per current guideline, what guidelines is, if we are we have performed PTCA with this for acute coronary syndrome, then for at least 12 months we have to take or we should continue DAPT. If the PCA is performed from chronic coronary syndrome or ischemic heart disease, then for we should continue DAPT at least for 6 months. But this data they are taken from the guidelines, and these guidelines they are following some older tracks with older generation of strains. So with new generation of strains and with some recent data, they have shown that some recent data and trials there is the reduction in the bleeding events with even with the short-term DAPT and with a comparable ischemic outcome. So the optimum duration of the DAPT after PCI is still under debate. So for the reduction of the bleeding risk in the first 12 months after ACL post PTI, there is two types of strategy for the reduction of the bleeding risk. First one is the abbreviated DAPT strategies. That means to reduce the duration of the DAPT either 1 month DAPT or 3 month DAPT or 6 month DAPT instead of 12 month DAPT. Second strategy is the DAPT de-escalation strategy. That means to use the lower potent drug like clopidogrel or aspirin instead of Ticagrelor or Ticagrelor, or using the single antiplatelet with lower potency. So moving to our question, can we shorten the DAPT by stopping the aspirin and maintaining the clopidogrel after 3 months? Yeah. So the data available for this strategy is one trial is the DAPT2 trial and the second trial is the SMART choice trial. These two randomized controlled trials provided the encouraging results on the safety and efficacy, both for the short-term DAPT for 1 month and 3 months respectively, among mixed population of the acute coronary syndrome and the chronic coronary syndrome undergoing PCI. So, according to the stop DAPT trials, it includes the patients who have undergone PCI with deaths. Among these, the ACS population was around 38% and the CCS population was around 62%. In this study, short-term DAPT of 1 month, only 1 month, followed by clopidogrel monotherapy for 11 months was compared with the standard DAPT duration of 12 months. The primary endpoint was the net adverse clinical event, that is the composite of mass plus any major or minor bleeding at the 1 year. And in this study, superiority for the primary endpoint, that is the net adverse clinical event, was achieved at 1 year when compared with the standard DAPT therapy of 12 months, which was particularly driven by the reduction in the bleeding events without any increase in the ischemic component, that is the composite of CVD, stent thrombosis, and stroke. So that is the short-term DAPT of 1 month followed by clopidogrel monotherapy. There is a superiority for the bleeding events with comparable ischemic outcomes. Next trial is the SMART choice trial. In this trial, patient undergoing PCI with this with ACS around 32% and for 58% and the CCS around 32% was compared with the standard DPT for 12 months. In this trials, short DPT of 3 months followed by the any P2 vital inhibitors, either prasugrel or ticagrelor or the clopidogrel for 9 months was given, and it was compared with the standard DPT therapy. The primary endpoint was the major radical MS rate, which in this study there is significant lower rate of bleeding in 3-month DPT therapy when compared with the 12-month DPT therapy with comparable ischemic outcomes. That is the primary endpoint of MS. So, and also there is one larger meta-analysis which compares around 6 trials. It shows that the short-term DPT less than 6 months when compared with the prolonged or standard or prolonged DPT more than 12 months associated with the lower bleeding risk without any significant increase in the ischemic risk. So, based on data from this trial and meta-analysis, we can say that from the recent data, we can switch to the clopidogrel and stop aspirin beyond 3 months if required, particularly in the high bleeding risk patients. Now moving to our second question, what is the role of clopidogrel beyond 1 year as a single antiplatelet therapy instead of aspirin for the secondary prevention in the patient with atopic dermatitis? The data for this strategy, that is the host extended trial, and second one is the smart choice 3 trial. In the host extended trial, the patient was divided into the 2 groups after completion of the standard duration of the DAPT, that is 6 to 18 months. After completion of the standard duration of the DAPT, either patient receives clopidogrel 75 mg and the patient receives aspirin 100 mg. The primary, the clopidogrel monotherapy significantly reduced both the composite and point of combination of thrombotic as well as the bleeding risk. There is 26% relative risk reduction for this primary composite endpoint. There is 34% more relative risk reduction in the clopidogrel monotherapy group for the thrombotic endpoint only, and there is 26% more relative reduction when compared with the aspirin monotherapy in the clopidogrel monotherapy group for the bleeding endpoint of view. And the discontinuation rate was also higher in the aspirin monotherapy, so clopidogrel is better tolerated in this trial. So we can say that from this trial, long-term treatment with the clopidogrel monotherapy leads to consistent reduction in the CV events with when compared to aspirin monotherapy, even with reduced bleeding risk. Okay, so and one another meta-analysis which was published recently in the Lancet trial in August 2025, which includes 7 major randomized control trial and around 29,000 patients with median follow-up of around 2.3 years. This meta-analysis shows that at 5.5 years, MS was less common in patients who assigned to the clopidogrel monotherapy as the maintenance therapy than in patients who assigned to the aspirin monotherapy. So this data from the trials in this meta-analysis shows that the clopidogrel monotherapy is superior to aspirin monotherapy for MS prevention with no increase in the risk of bleeding, and it supports the preferential use of the clopidogrel over aspirin for the secondary prevention in patients with atopic dermatitis disease. So, thank you.
Thank you, Vishal. Our next speaker, we have a discussion at the end of the session is Dr. Vishal Sharma. I'm going to talk about Rosuvastatin is more potent alternative, but Dr. Vishal Sharma.
Very good morning to one and all. So let's take this talk forward. So actually, I have kept the slides very simple. Try to bring the message in a very short and sweet format. So the clinical context of our patient is he is a 36-year-old male. He is smoker and has undergone plasty, which is for an ACS event, and he has undergone this 4 months back. So this becomes it becomes complex. We say in terms of the fact that he is young, he has risk factors, and he had an ACS. He is currently on aspirin with Ticagrelor and Rosuvastatin, almost a good GDMT. But the dentist now advises that you have to stop the blood thinners. Good that the physician has taken the effort to let the patient undergo EMD, which is negative, and his ratio fraction is good. The question is, what would be the optimal EAPT duration and strategy for this small procedure? Now let's go to the guidelines and I'll just summarize what do the guidelines say at this point of time. For any ACS event, the default therapy of antiplatelet is 12 months, and that is accepted worldwide. But if you think that the bleeding risk of the patient is little high, you can reduce this to 6 months. Yes, that's true. And in selected cases, we have the trial supporting the fact that you can also reduce, the potency of antiplatelets at 3 months also. We have the Skylos trial, we have SAPT trials. So for this patient particularly, I think we did not switch because most of the trials have clearly shown that switching the drug at 3 to the first 6 months can be hazardous unless until the patient has real indication to switch that molecule. So for this procedure, you can just continue with the aspirin, stop Ticagrelor for 3 days and resume the Ticagrelor within 24 hours as soon as the procedure is done. So let's see how do we discontinue in case the patient is on different antiplatelets. You need to understand the fact that how these antiplatelets act in terms of their pharmacology. Both claudication and prasugrel, they are prodrugs. They are converted into their active form and then they inhibit the P2 vital receptors irreversible. So that is important to understand. Ticagrelor, on the other hand, is not a prodrug; it's a reversible binder. So, it gets dislodged very easily. So, if the patient is taking Ticagrelor, it is true that he would have less ischemic event, but it is also true if he discontinues the drug for any short duration, he will be at high risk of having any thrombotic event. So, in this patient, if the patient is taking Ticagrelor, you need not just switch to any other molecule, you can stop the Ticagrelor for 3 days. Had he been taking prasugrel or clopidogrel, yes, he would have required stopping that drug for at least 5 days, both clopidogrel and prasugrel, because they are irreversible inhibitors, and in case you take the patient early, you will have uncontrolled bleeding. The other question is, how do we switch in case we want to switch? You should not be switching the drug in the first 6 months. Again, I'll tell you, most of the guidelines and trials support that fact. But if you are switching from Ticagrelor to prasugrel, you need to stop Ticagrelor and wait for 24 hours. Now, most of the people sitting here would argue that wouldn't stopping the drug for 24 hours be leading to ischemic event? The answer is no, because there have been a good amount of trials like the SWAG2, SWAG4, post-reduced molecular ACS trial that clearly shown that stop Ticagrelor, wait for 24 hours, but then when you are after 24 hours, you have to completely load prasugrel with 60 milligram and then continue with 10 milligram per day. However, again, remember, prasugrel in most of the trials has shown to reduce the ischemic events, but yes, increase the bleeding events, and the subgroup analysis showed that you should avoid prasugrel in patients who have stroke, PIA, or any high bleeding risk. Of course, this patient is not into that case. So just to summarize, our case was very simple. He was NSTEMI, young patient, did not switch the antiplatelet because that would be a really high risk case. You just stop Ticagrelor for 3 days, continue with aspirin. Ticagrelor is a reversible inhibitor. You have faster platelet recovery. Let the patient undergo dental procedure, and then within 24 hours again start Ticagrelor. This was the best approach for this patient. If in case you want to switch the patient after this surgery, you have to wait for 24 hours, load with Ticagrelor, and load with prasugrel and then continue with 10 milligram per day. Always a proper coordination between cardiologist and dentist is required whenever you are doing some small procedures. Thank you.
And for further discussion, we have Dr. Pooja Vyas, who is going to come on the dais.
So we are talking about, good morning all, we are talking about switching antiplatelets and de-escalation. But this young patient who is only 39 years old and also a smoker, so he falls in high ischemic risk category. And he is only going for some dental procedure, and as per American Dental Association guidelines released in 2022, if patient is going for simple dental procedures like tooth extraction up to two teeth extraction or some periodontic or endodontic procedures, patient does not need to stop antiplatelet therapy. He can continue dual antiplatelet platelet strategy. And my topic of discussion is Ticagrelor can be used as single antiplatelet strategy in PCI setting. So recent guidelines just released in 2025, it shows that if we want to reduce bleeding in high bleeding risk cases, only class 1 recommendation is for SAPT with Ticagrelor after short duration of DAPT. So this is the only Ticagrelor monotherapy is the only therapy which has got class 1 indication after a short duration of DAPT in the beginning. So for first 1 to 3 months, patient should take DAPT, aspirin and Ticagrelor. And if patient has not developed any adverse event, and here we mean that patient has not developed any ischemic event or any bleeding event while patient is taking DAPT, and patient is falling in high bleeding risk and patient is not at high ischemic risk, then only we should switch them to single antiplatelet strategy after 1 and 3 months with Ticagrelor monotherapy. Other therapies like de-escalation therapy and to like switch to single antiplatelet therapy with aspirin or like P2Y12 inhibitor with clopidogrel is class 2B recommendation as per recent guidelines. And what is the rationale for this de-escalation strategy? But because patient remains at high ischemic risk during the first 3 months because of like thrombotic risk and also inflammatory milieu and platelet hyperactivity, and this risk is reduced after 3 months due to intensive control of the risk factors, while the bleeding risk remains static over a period of time. And this class 1 recommendation for Ticagrelor monotherapy has come from Ultimate DAPT trial. In this trial, this is randomized, double-blind and placebo-controlled trial where they randomized 3,400 patients to Ticagrelor and aspirin group versus Ticagrelor and placebo group. And they did 1 year follow-up. Patient took 1 month of standard DAPT. After that, patients were randomized. And at 1 year, they found out that clinically relevant bleeding was higher in Ticagrelor and aspirin group, but for versus Ticagrelor monotherapy group, 2.1% with significant p-value and hazard ratio of 0.45. And while ischemic events measured by MACE, they were all like p-value met the was significant for non-inferiority. Another trial published in NEGM in 2019, it also randomized 9,000 cases and 7,000 cases were randomized, and they also studied primary endpoint was BARC 2, 3 or 5 major bleeding, and secondary endpoint was MACE events, death, MI or stroke. They also found out that there was higher bleeding when patient was taking Ticagrelor with aspirin as compared to Ticagrelor monotherapy, and there was no significant like the key p-value for non-inferiority was met for ischemic events. So take-home message was that in high-risk patients who underwent PCI and were treated with Ticagrelor and aspirin for 3 months without any major adverse event and antiplatelet strategy of continuing Ticagrelor monotherapy, it led to substantially less bleeding and without increasing the ischemic events. Another meta-analysis done in several randomized controlled trial with 53,000 patients that also showed that short DAPT duration post PCI with days it reduces bleeding without increasing ischemic complications, and monotherapy with high potency P2 Y12 inhibitor is preferred over aspirin or low potency P2 Y12. Another question is, can we use Ticagrelor in hepatic and renal failure as well? So in renal impairment, there is no dose adjustment is required, while in hepatic impairment, if it is mild to moderate hepatic impairment, dose adjustment is not required. And there was trial Jupiter 11. The objective of the trial was to compare clinical outcome in patient with acute coronary syndrome and CKD with eGFR of less than 30, and they compared Ticagrelor or prasugrel versus clopidogrel. And they found out that Ticagrelor showed mortality benefit at 1 year in high-risk STEMI patient with advanced renal failure. And in hepatic dysfunction, if patient has mild hepatic dysfunction, no dose adjustment is required. If patient has moderate hepatic dysfunction, then it should be used with caution, and we should consider alternatives if patient's bleeding risk is high. And if patient has severe hepatic dysfunction, then it is contraindicated. As we are discussing, now future need is precision medicine. So we don't have that strategy like that that fits all the sizes. We have to decide which patient will go for like 12 months DAPT if patients. We have to decide ischemic risk of the patient, and we have to decide the bleeding risk of the patient, and accordingly we should choose that whether patient needs 12-month DAPT or short DAPT with Ticagrelor monotherapy further on. Thank you.